but it's okay. Welcome back. Another episode. Happy Friday, y'all. How's everyone
What's
doing?
going on, guys?
What's
Good,
up,
good. How are
man?
you guys?
Pretty
We have a
good.
lot of interesting topics to talk about today.
It's going to be a fun-filled episode. So let's get started right away. Wanted to start by the news of the week. Rite-Aid seeks Chapter 11 bankruptcy protection as it deals with lawsuits and losses. James, you want to take on this one?
Yeah, let me share the article. So Rite-Aid is a pretty major pharmacy chain. You know, they're publicly traded as well. I think it's been trading sideways for the last, I would say, decade or so. But they recently filed Chapter 11 bankruptcy. So they're trying to restructure the entity. But Rite-Aid has pretty much said a lot of the settlements that they had to pay out for the opiate crisis have negatively affected how much they've been earning in revenue. So I think, they've attributed that to being a huge loss. Some of it also to just reimbursements being less than what it was before. But I know they've said there's about, I want to say 200 some stores that will be closing as part of this restructuring. But what's kind of interesting is that we have a lot of pharmacists walking out, not just of Rite Aid, but other stores. And on top of that, we have a lot of different retail stores that are closing down. It's kind of an interesting time. There are some, when I was looking at some articles of, Rite Aid closing down in certain states or certain cities, it seems like this is a pretty big deal because a lot of smaller cities, they only have Rite Aid there. They don't have a Target. They don't have a Costco. So it's going to consolidate a lot of prescriptions at just one pharmacy location. And I kind of wonder, we're obviously larger metropolitan cities than most people, but I wonder how difficult it will be for a lot of patients moving forward, knowing that their pharmacy is being closed down and they have to travel, 10, 20 miles to the next closest pharmacy after that.
Yeah, I mean, with a lot of rural cities, there's usually just one big box chain that was there. Like we have a pharmacy in a rural city, and at the time when we were there, there was no Rite Aid, no CVS, no Walgreens, none of that. The first Rite Aid opened, and then I think it was 6 or 7 years after that that a CVS came into town, and then another 2 to 3 years, then a Walgreens came into town, and then a Walmart came into town. So for towns and cities like that, if the only pharmacy there is no longer there, then that entire subset of patients have to find another option, right? And like you said, sometimes it's 20, 30 miles. Sometimes it could be even further. If it's a really rural town that's, in the middle of nowhere, it might be a 40, 50-mile drive just to go get your prescriptions, which it's kind of crazy that in this
Yeah,
day and age, the access to care is still limited in that sense to a lot of these towns and cities across our country.
yeah. I think this was like one of those like slow moving trains, like disasters that you saw coming for Rite Aid.
Mm.
They've been, as James mentioned, pretty much on a downhill spiral for the last decade or so. I know a few years ago they tried to sell with Walgreens, I
Yeah, it
believe
was
it was like maybe 2018 or something like that.
15.
And I
Yeah, it was
think
a little earlier.
It was earlier. Yeah, I know Walgreens ended up buying a good chunk of their stores, and they've kind of always been third to the two bigger players, which are Walgreens and CVS. Obviously, it's unfortunate. I know that I read like the news. I think you mentioned James, like somewhere between 150 and like 200 stores are closing. It's like I believe like 30 or so here in California. The one actually like right by my house is going to be closing down. So obviously creates an access issue because there's people that have been using those pharmacies, or you're used to the staff, they're used to the location. So now you have to kind of uproot them and have them get established somewhere else. This is kind of compound on our conversation from last week with stores already being understaffed and overworked. So now they're going to get more volume, probably not increase staffing or increased hours. So it's just going to add on to the stress for the stores nearby, in addition to disrupting all these people who are using these locations. And then, to kind of piggyback on the patients who are going to be impacted in rural cities. I was working in the Central Valley for quite some time, and it's unfortunate. I mean, people do literally have to drive 20, 30 miles to go to a pharmacy, and sometimes if you're in the middle of the night, you have to go to an urgent care and see a doctor. there might not be a 24-hour pharmacy, within 50, 60, 70 miles. So you have to drive upwards of an hour to go get your medication. So it's pretty big. I'm not too familiar with the bankruptcy process. Maybe James or Armor, if you guys have some insight into like what Chapter 11 means, and if this means all the not Walgreens, sorry, Rite-Aids will close, or if it's just going to be kind of a restructuring where they'll still remain, but some things might be different. So if you maybe have some insight into that.
Yeah, I mean, I can talk about the bankruptcy portion, but I do want to actually get your thoughts on it, something adjacent after that. But typically, there's two types of bankruptcy. There's Chapter 7 and Chapter 11. Chapter 7 would be considered a liquidation, meaning the company would be effectively winding down and selling off its assets with the plan to cease business operations. And a Chapter 11 would be a restructuring. In a Chapter 11, it's just that typically the expenses exceed the amount of income that a business is generating. And as a result, it's a formality to announce to the courts like, hey, we're basically not making enough and we need to restructure who our creditors are and how much we're paying them. So it's supposed to sort of, address the debt service that a company is taking on, whether it's too much and they're still saying, hey, we're still good for it, but we just can't pay at this rate that is occurring right now because our revenue has decreased or our expenses have increased. But that's essentially the difference between Chapter 7 and Chapter 11. Rite Aid is going through a Chapter 11 bankruptcy. So, they will probably come out of this stronger, I imagine. But again, it just sucks. They have to close some stores and the access to care will diminish. But one thing, I was talking about this conversation of, Rite Aid filing for bankruptcy. There's a lot of stores that are closing down, not just, outside of Rite Aid, but, CVS, Walgreens. I think they're closing about 200 stores each. But sort of when I was talking to someone outside the pharmacy industry, sort of the comment I received and heard was, it sounds like pharmacies are getting more efficient if they have to close down more stores. And it was kind of interesting to hear that because from an outsider perspective, they're thinking, oh, there's just too many pharmacies. There's probably more access and points of care. But I thought that was kind of an interesting thing to sort of hear. So I kind of wanted to get your thoughts. Do you think because there's so many pharmacies closing down, do you think care is becoming much more efficient, or is it because revenue is dropping for a lot of different chain and independent pharmacies from the PBMs, which makes it harder to survive? But I kind of want to get both your thoughts here on this conversation I had.
Yeah,
Yeah, I can
I think
go ahead, Travis.
if you want to go, all right, thanks. I'll be quick. I think if you guys go back to when we were maybe 10 years ago, 10, 15 years ago, like still in college or about to start pharmacy school, there's a lot of consolidation that took place in the industry. PBMs merging with each other, then eventually these PBMs vertically integrating with like health plans, which medical carriers. So if you think of like Optum, RX, and then United Healthcare, these occurred. And then same thing was happening with chains. I know like CVS bought out Target, which was like really big news around the time we're finishing pharmacy school. As we mentioned, the Walgreens purchased about, I think it was 1,000 stores across the country, again, around that same time frame. And again, similar types of consolidations were happening. Walgreens and Boots Alliance joined, which is like a European chain. So all this happened, and it was a ton of stores. I live close to where there's two literally the same chain pharmacies across the street from each other. The same chain. Like it used to be a different store. They bought it out. They just changed the name, put their name on it, and both of them are still operating. So I think it was a bit of again, one of those things that was bound to happen where there was just a lot of excess where you had a lot of different stores. But I don't think necessarily they were more efficient. I just think there was just too many pharmacies. That's my kind of take on it, where it's just one of those things that there was maybe a surplus of stores and they're consolidating. But I think the efficiency aspect, I wouldn't really say so. I think it may seem efficient on paper, but if you walk into the pharmacy, it's for this. I think we just talked about it again. What's the staff just being completely overworked? So I think I wouldn't say efficient. I just think it's something that having two stores across the street from each other from the same chain didn't make sense, and they're just doing smart business and getting rid of some of those extra stores.
I think it's a little bit of both. I never looked at it in the perspective that that person brought up to you, James. But now that I've thought about it for a little bit, in a sense makes sense. So Pogos, you brought up the consolidation 10 years ago or so. That consolidation was purely for expansion. If you remember at that time, they bought up those smaller chains or they bought up the smaller pharmacies and they just put their name on that store and just increased their locations. So the consolidation at that time was actually for expansion. I think right now the consolidation that's happening is the exact opposite. I think they overexpanded, which a lot of these articles say that these pharmacies have overexpanded. When you get to that point where, like you said, you have two stores right across the street from each other, both have to pay the pharmacists, the technicians, the clerks, the entire store staff, all of that expense put together compared to the income that these pharmacies are bringing in, it's just spread too thin. Or if you look in the case of Rite Aid, they have, I think it said $680 billion of losses to date for this year. All of those losses across all of their 1,900 stores, it all adds up. If you don't have enough revenue coming in and all of your revenue is just going out to keep these stores running, well, it just doesn't make sense. So I think a lot of this consolidation now, it can be spun into the sense of efficiency, but I think it's just going to be consolidation for patients to, maybe a Rite Aid sees 10,000 patients a month. Well, now they're going to see 15,000. Another Rite Aid that's 10 miles down the road, they're going to see that extra 5,000 as well. And it'll just consolidate into that. The only issue that I see is the access, like we brought up before. If patients have access to their pharmacy right down the street, well, that Rite Aid closed down or that whatever other pharmacy closed down. Well, now they got to go 15 miles across town to go to the same pharmacy, the same Rite Aid or the same CVS or whatever it is. That lack of access is going to be hindering for patient care, in my opinion. I know on the finance side, people will probably think it's just a consolidation for financial purposes, but it's going to bring a strain on a lot of patient care and access to patient care, in my opinion. And we're not going to see how that unravels till these stores are closed down, in fact, and a lot of these patients are scrambling. The Rite Aid that closed down near me, the patients were told the day of that the store is closing down tomorrow and to get all their prescriptions transferred. So just think about hundreds or thousands of patients all being told today on Friday, hey, the store's closing down on Monday, it's not going to be open, transfer your scripts. How much of a strain does that put on the patients, the other pharmacies in their area, the providers if they're controls and they got to send you scripts? All of that is a cascade of problems because there's lack of communication or whatever it is, whatever the reasoning is behind it or the justification, it just doesn't justify the means of how they're doing it, in my opinion. But we'll see how it unravels, to be honest. It's not just Rite Aid, CVS, Walgreens, all the chains are having stores closed down. James, if you want to bring up the next article, that kind of gives us the numbers for the other two big chains. So it says on here, Rite Aid is going to close about 400 to 500 stores of its approximately 2,200. And I think between CVS and Walgreens, CVS was about 244 stores, and then another 900 by 2024, and Walgreens closed 200 in 2019 up until now, and then 100 additional 150. So it's about 1,000 stores if you add all the numbers up together, a little under 1,000, nationwide.
That's a pretty big chunk. I think there's about maybe 70, 80,000 pharmacies nationwide, roughly. So that does represent a pretty big chunk already. Right. A couple thousand stores.
I think it's like 57,000 stores, pharmacies across the country. Things like that.
Yeah, okay. But I think just for right. retail chains is about 21,000. That doesn't include like the grocery stores, the independents, the mail orders, all that. So just of the three big box chains, it's about 21,000.
Yeah.
So you're losing 1,000 of those 21,000 stores. That's quite a lot, especially if they're in those rural areas.
I think just another thing to keep in mind, besides just being a pharmacy, a lot of these places, they offer, they sell food, they sell over-the-counter products, they sell home goods, they sell toiletries, etc. And a lot of, we're here and sitting in LA and Orange County and, whatever. We have so many different places we can go to. But again, just to kind of add on to that, those folks that are like in a food desert or somewhere in a rural area where there just might not be another grocery store, that's also another impact too. That's not necessarily tied to their drugs, but now if you have to go again to the next town over to purchase groceries or to get milk. It's just one of those other barriers that kind of is created, I guess, or like an hindrance that's added to these people's lives just by these stores obviously closing. So very unfortunate, and
It's
some people don't really.
it's the
Go ahead.
access is there. And you have to go 15 and 20 extra miles. Like maybe a lot of people think, okay, driving 20 extra miles, like that's not that big of a deal. But you have to also factor in driving that 20 miles each way. That's 40 miles. That's 40 miles of gas that you're gonna also
That's
spend.
$10
And
right there.
yeah, and gas is through the roof right now. Like $6 a gallon. It's insane. So
Yeah,
it's
it's
like,
like
okay,
10, 20.
you're driving 40 miles to go get one prescription from your pharmacy, and you're spending $10 just to get there and back on top of the $20 or $30 you're going to spend on your prescription.
So
It's
Yeah.
can I go a little off topic here, guys? What are your
yeah.
thoughts on mail order? So we know mail order pharmacies exist. I mean, we've been kind of like talking about chain pharmacies, mostly retail. Um, Obviously, someone can say, you know what, these people in rural areas, if they have to drive 40 miles, well, they can just use a mail order, get their medications, their maintenance medications from mail order. If they need something right away, then they can maybe take a trip to a pharmacy once a week when they go grocery shopping. What
Mhm.
do you make to that argument? What are your general thoughts on like a mail order pharmacy experience from like a patient perspective, and you know, just kind of get your thoughts on that.
I got a lot to say about
J-
that.
James, you're smirking, so maybe if you want to
I got
want
a
to.
lot to say about that. I mean, look, mail order pharmacy, it works, right? It's great. You get it mailed. It's perfect. But for a lot of people, they need that face-to-face interaction with a healthcare provider, with a pharmacist. Before in the past, mail order pharmacies, they would be subject to a lot of waste. I used to see a lot of different pictures where someone would get almost like a 3 years worth supply of medications delivered in a month, and that patient would pass away, and then the pharmacy would still continue mailing medications to that house. I think the other crux behind this is on the business side, a lot of PBMs, and you have Mark Cuban, who have opened up mail pharmacies to say, hey, look, we can address the entire nation. We're able to handle all pharmacy services for everyone here in the United States. The business model itself is just not scalable. And it's not scalable because the reimbursement rates that are given. It's not scalable because the customer demographics, some of them are on certain insurances that exclude them from using certain pharmacies. And if you're not in network, you can't use that specific mail order pharmacy, or you can't even use a mail pharmacy at all. So there's a lot of issues with mail order itself. But for some people who are on the younger side, they're probably getting one medication every 3 months. Yeah, it's perfect. But for a lot of other people, say they're on Medicare, say they're on Medicaid, and they have a lot of different comorbidities. They might need medication changes that need to be addressed immediately. Antibiotics, anticoagulants. Mail order is not a fit-all solution for everybody, and it's just not a scalable business. It's just not. It's very difficult to do so. So those are kind of my thoughts on mail order. It works for some people, but again, it's not for everyone.
I'm pretty neutral on mail order. That's about all I'm going to say. Yeah, it's an option. It's not the best option. For some people, it might be the worst option or the best option. It just really depends patient to patient. James, if you can toggle over to the next one, I wanted to show you guys the transition of kind of how retail pharmacy is going over the last 10 years. And we brought up mail order, so I want to show you guys a very interesting chart. We talked about reimbursements being the biggest constraint over, excess of stores and staff, and then understaffed in places that need it. But yeah, stop right here. So if you look at this chart, retail chains take up the most locations and the highest total prescription volume at 2.9 billion per year. Annual revenue of about 163 billion across 21,000 locations. That works out to about 138,000 scripts per location. You go down to regional pharmacies, which are your grocery stores, your convenience stores, your Dollar Generals, all those places that are now opening pharmacies. They take on about half of the prescription volume, with about what is that, a third, or no, about half of the
More.
income as well across 16,000 stores. Independents, that number gets even lower. What's crazy to me is this mail order online pharmacy section. They only do 0.6 billion, so 600 million prescriptions annually, but the revenue is 187 billion. So, like, as I was reading this article, I just stopped right here and thought for a few minutes. I'm like, the numbers are not making sense. You know, mail order is super efficient, and a lot of people are using it. The volume is very low. The profit is very high. But these mail order pharmacies may or may not still be struggling. So that discrepancy just didn't make sense to me. I want to get maybe your guys' thoughts on that.
Yeah, I'd love to chime in. There's one big caveat to that number.
Yeah.
Actually, if you look to the column all the way on the right, it says it's basically specialty medications. Most of basically every single PBM it owns a specialty pharmacy.
Yep.
And the reason that volume is so low and the dollar amount so high is because you only have maybe 1% of your population taking specialty drugs. When we say specialty drugs, I just wanted for the audience to kind of clarify what these are. These are medications that are used to treat cancer, very debilitating conditions. Again, we mentioned like rheumatoid arthritis, and some of these drugs cost $5,000, $10,000, $15,000, $20,000, $50,000 a month in and month out for these patients. So even though they're about 1% of the population who's using prescription medications, they make up about 50% of the drug spend, patients on specialty drugs. So the reason that mail order numbers are a little inflated compared to the other categories, most specialty pharmacies are going to be by mail delivery. There's very few pharmacies that you would walk into and be able to obtain some of these cancer treatments without being a specialty pharmacy. So most of these will be through mail. There's obviously some benefits by having these specialty pharmacies. They're accredited. They have specially trained pharmacists. They have specially trained nurses that can provide better care. They have more touch points with the patient. So they're able to kind of monitor them and work directly with their doctors and be more hands-on and more high touch. But just kind of like carving out mail order traditional and mail order specialty, I think that number would be a little different.
Mm-hmm.
Oh yeah, for sure.
There needs to be, a distinction between the two. And it'd be nice, but we're never going to see these numbers to see what this revenue versus what the actual profit is. But, good luck with that. It's just,
go ahead.
So
go ahead. I just was going to add another follow-up question. So, to the point of mail order, we all use Prime. Probably more than we want to admit. What do you? I've used it 4 times this week already. I'm being honest. I ordered like vitamins. I got like a mite coming in. I get my groceries through Amazon. I don't really know where they stand in terms of their pharmacy. I know when I log on, there's like a pharmacy tab that you can click on. I haven't used it. We know there's other players, and James, you mentioned like Mark Cuban's pharmacy, which I think is a little bit of a different model. But what do you think of the point where like Amazon actually kind of gets a little bit more established? Let's say in 3 to 5 years from now, where you can basically have Prime Now on your meds and your groceries, and your toiletries. Yeah. So what do you think the impact's going to be? Just kind of like,
I don't know if you
like
can
in this case.
Yeah, it's going to be really difficult to do same-day delivery or 2-hour delivery with medications. I think a big constraint of that really comes down to insurance billing. You have to make sure that you're getting paid for your prescriptions before you even dispense it. Otherwise, why would you even sell the medication? And I think that takes up a crux of the time for a pharmacist when it comes to dispensing medication. We have to check eligibility, make sure it's covered. Will the insurance accept this for future refills, or is this like a one-time credit or one-time fill? I've looked at Amazon's pricing. I've compared to GoodRx. I've compared to Mark Cuban's pharmacy. I wouldn't say they're cheaper. I wouldn't say they're more expensive, but they're sort of like in this healthy medium of being in the middle. You have Mark Cuban's pharmacy. What he's doing is pretty cool because he doesn't participate in a Medicaid and Medicare program. It's purely just a cash business. It's easier for him to compete. they're not subject to like a most favored nation clause, meaning they don't have to charge the same rate they do to insurance to their cash customers. So I think that's pretty cool. But a lot of the generics he's been offering as like, touting as super cheap, it's been like that well before he's even come in. The reason why medications have always been really expensive is because of this most favored nation clause. If you recall, Target, Walgreens, and a few other chain stores back in the early 2000s, they had like $2, $3 generics at the pharmacy. The problem is CMS came in, did an audit, and said, hey, look, we've noticed that you've been charging customers $2 to $3 for these generic medications, but you're invoicing us, the federal and state government, $20 to $30 for these same exact medications. As a result, there's a clawback for this. So it's not really because medications are more expensive. I mean, they are going up in price, but it's really because the rules and regulations behind how these medications are billed. That's why for a lot of customers, they still have to pay out of pocket tremendous amounts when they go to these pharmacies. I admire what Mark Cuban's doing, but when I look at his business model, it's just more of a referral agency to a mail order pharmacy that he works with. It's not really a pharmacy that he owns. It's just not a pharmacy he operates. It's just a marketing feeder. I kind of actually covered this in a different YouTube video about Mark Cuban's pharmacy. I think traditionally, on average, most pharmacies would make a profit margin of roughly anywhere from 15 to 20% on the medication. For Mark Cuban, I mean, he says there's a 15% markup plus a $5 flat fee. For a lot of his medications that Mark Cuban has, they're already at a low cost basis. So the math actually works out to have a margin of anywhere from 70 to 100% for most of the medications he's filling. So do I think it's disingenuous? No, not really. He's being really upfront with the pricing, but I have to say, like, it's his margin percentage is definitely a lot higher than what other traditional pharmacies have. So that's, again, my input. I know that's long-winded.
Yeah, I think mail order over the course of the next 5 to 10 years is really going to find its footing and its groove. Amazon tried to do it, I think, a little too early in the game, where a lot of people weren't necessarily comfortable with having their medications mailed to them, or 2 hours, or it's you normally associate Prime and Amazon with things and goods that you need or things that you want to order. No one really associated with medications, so it's going to take a time for people to transition to it. What's going to be interesting is why people choose mail order over other traditional pharmacy styles, and the reasoning behind that. James, if you can scroll down a little bit, there's another chart that shows kind of the thought process behind patients and how they pick their pharmacy. I wanted to get your take on this, coming from an independent pharmacy background. What you think of this, and then Pogos, maybe you have. Keep going. Keep on going. Right here. So as you can see by this chart, different factors that patients use to pick their pharmacy. Primary thing is my insurance covers this pharmacy, and distance to my home and office. Those are kind of no-brainers. But if you keep going down and you see service quality, store hours, price, accessibility, pharmacist knowledge, healthcare provider recommended this, and even personal touch and all these things. What is your take on this chart? Because I can speak from experience. After you get past insurance, distance, and service quality, the rest of the chart needs to be flipped on how my patients select the pharmacy that I have. It's always the personal touch. It's always the additional services. It's always the healthcare provider recommendations, pharmacist knowledge and input, reputation, then store hours and prices and accessibility. All those are kind of secondary and tertiary factors, at least in my experience. But I want to get your guys' take on whether you think this is accurate or this is just a general population type thing. What do you guys think?
I mean, the survey size is about 5,004 people.
Yeah, I was
So
Yeah,
looking at
it's a small sample
that.
size.
it's a
Yeah.
small sample
Who
size.
are
So
these
it could really,
respondents? Are these individuals or
yeah.
are these like pharmacists that are answering on behalf of the patient? I guess that's my
I
question.
believe it's individuals.
Individuals. Yeah, that's my
Sounds like
guess
it's
too.
really
I don't
small.
really, yeah, I
It's
don't
too
really
small
know.
of a sample size, but it was.
Too small of a sample size, so like a few people can sway it in one way or the other. I mean, I kind of agree. I think ultimately you want to go to like something that's in network and your prescriptions will be covered there,
Yeah.
and you don't want to drive 20 miles when you can drive like 2 blocks. So that really
Yeah.
makes sense. But as far as like, I think, store hours, yeah, I mean, that's kind of like important. If something's closed on the weekends, if they have limited hours, like they're open from like 10 to 5, but you're at work, you can't go, that's obviously an impact.
Right.
Everything else, I do agree. I think like in terms of personal touch, having additional services, definitely refill reminders, appointments, a reputation in the community, a recommendation from your physician. Hey, this is a trustworthy pharmacy. I think those are pretty important. But I'm actually just kind of surprised how low those numbers are. Like I thought
That
it would
that
be
was my point. Yeah.
not that the order is not like so much of a concern for me. I mean, that's gonna like flip here and there, but that like only 21% of these people said a personal touch matters. So I guess it's just become so transactional now that you don't really care if the person at the counter knows you and can kind of like have that one-on-one relationship with you. I think it's just basically give me my meds, I need to go, and that's at least from my experience, like limited retail experience. It's people were just a-holes sometimes. They didn't really care about you, and you tried your best sometimes to just address them by their last name, ask them how they're doing. But most people are just like, I need my meds and I need to go. Give it to me right now. And it's kind of I think it's a cultural shift that we've had that maybe 20, 30 years ago, you would have that great relationship and the patients would come to you and it would be you have the ability to talk to them and get to know them and they'll get to know you. But I feel like in today's age, everything is me, everything is now, and everything is fast. So it kind of, I guess, makes sense if you look at it through that lens.
Well, we talked about mail order, so based off of what you just said, it seems like mail order would be the natural transition option, right? To shift to for a lot of people. If the personal touch doesn't
Yeah.
matter, the additional services don't matter, knowledge and input doesn't matter, then it's like buying, supplies off of Prime. Like, oh, I need a re-up on my protein powder. It's like, okay, I need a
Yeah.
re-up on my Lipitor prescription for the month. And I don't need any interaction with anyone because it's something I always take.
So
So,
I'll end it on this note, and maybe we can move on to our next topics. I know that's quite a juicy topic as well. But a few years ago, I was at a conference and they had a pharmacy vending machine. So
oh
basically, the
yeah.
medications are preloaded and ready to go, and you would just walk up, present your information, and you'd be offered a consult virtually, like basically a FaceTime consult with a
Mhm.
pharmacist if you needed it. Otherwise, there's your medications. Like it's kind of like getting a Diet Coke and a bag of chips from a vending machine. So I'll leave it at that, and maybe we can move on to the next topic.
Diet
That's
Coke
pretty funny.
chips and your monthly Lipitor prescription all in one.
Yeah.
You got to sell
That's
both.
yeah. So we talked a lot about the issues with the walkouts and the pay and availability of staff and pharmacists and other healthcare workers getting paid enough for the services that they offer. I think that's a perfect segue to go into this next minimum wage that California set. Pogos, go ahead and tell us about this $25 minimum
Yeah.
wage.
So yeah, this article, I think this is probably something from earlier this week that came out. Governor Newsom here in California passed a bill that set a new minimum wage of $25 an hour for healthcare workers. So this is obviously good news. I think it kind of coincided with the end of the Kaiser strike that we talked about last week. So I believe all in all, somewhere between 400 and 500,000 individuals in the state will see a bump in their minimum wage. I think the statewide minimum wage, like it says there, it's about $15.50 an hour. It's going to 16 next year for everybody, but this one for specific healthcare workers will go up to 25 over the course of the next few years, depending on kind of the setting that they're working in. So you'll see it kind of stagger for some individuals, but that's the goal to get to 25. If you recall, earlier this year, there was another minimum wage law they passed for folks working at like fast food chains. I think that set their minimum wage up to $20. So it's kind of interesting that California is kind of leading this push to get individuals to a higher wage. We all know that inflation has been through the roof. Cost of living is high across the board, not just on medications, but on gas, energy, heating and lighting your home, food. So it's been obviously a positive for many of these workers, especially these are people that are not, your doctors, your pharmacists, your nurses, but they're like the technicians that may be working, a radiology technician or a janitor, people that are essential in keeping a hospital or healthcare facility operating. So definitely big news. My only interesting takeaways that you won't really find in the articles, but Amr, I know you went into the bill, and as did I. it's kind of interesting that pharmacy staff were left out of this. So this won't really apply to, unfortunately, pharmacy staff. So those technicians were also already frontline employees. Kind of talked about how during the pandemic, basically pharmacy staff, even technicians, are giving COVID shots during that time, and it's kind of unfortunate that this didn't really include them in there. I would have loved to seen it impact pharmacy clerks and pharmacy technicians, because they're, to me, vital, essential folks in the healthcare system that go, basically provide the utmost care to their patients and ensuring people are provided the best care, but they don't get into this mix. But otherwise, I just wanted to kind of share it as a bit of like a good news. I think it's a good step forward for a lot of people. I really hope that next time something like this happens, I really would love to see pharmacy included in this. Just get your takes on it, thought about the increase, thought about not including pharmacy, and kind of like where this goes in the future.
Yeah, I think the titles. Oh, go ahead,
I
James.
thought this included pharmacists. I
No.
mean, pharmacy technicians. Wow.
I read the bill. I read the actual
I
bill.
read the bill. It's unfortunately not the case.
Once again, pharmacy gets shafted again.
It's always what's crazy is the industry of pharmacy is notorious for having the short end of the stick every time. And the article itself is misleading. It's $25 per hour minimum wage for healthcare workers. Well, are pharmacy staff not healthcare workers?
No, we're not healthcare workers at all.
No,
we're not.
When we were in the middle of a pandemic and we were the only accessible healthcare entity for patients across the entire nation, were we not healthcare workers then?
It's kind of a sham.
Yeah, honestly, I'm pretty much reading. I'm reading this, and a covered healthcare employee basically means anyone like a nurse, physician, caregiver, medical resident, intern or fellow, patient care technician, janitor, housekeeping staff, groundskeepers, guard, clerical worker, non-managerial administrative worker, food service worker, gift shop worker, technical and ancillary service worker, medical coding and medical billing personnel, a scheduler, call center and warehouse worker, and laundry worker, regardless of formal job title. So I don't see, maybe, like they did include pharmacists, but I guess you could say a healthcare services provider, or I think there's something about a technician could involve a technician.
No. That sweeps it right under the rung. You're telling me that a technician that fills 400 prescriptions a day in a very intense working environment doesn't deserve to have their minimum wage the same as other healthcare workers. It's
pretty wild.
It's insanity to me. And we've all been in a crazy pharmacy setting. We know how stressful and how hard it is, for 8 hours straight. So I think it's a disservice, but that's my hard take. Hopefully it changes. Hopefully they re-review it. A lot of this is mainly for hospital workers. I do understand that, but there's also technicians and ancillary pharmacy staff within hospitals too. So you're telling me the rest of the
hospitals. It goes beyond, way beyond hospitals. It goes there's general hospitals, psychiatric hospitals, but it also goes into like nursing facilities, home health agencies, psychology clinics. So basically, it's a long list: physician offices, ambulatory surgical centers, etc. So I know we're kind of like, this is a little upsetting, but I mean, I know we're going to jump into the next topic, so I don't want to take too much time on it. But I just thought I thought initially when I read the headline, I was like, oh, this is great. When you kind of dive into the details, it was a little upsetting.
A little bit, yeah. Hopefully it becomes an industry standard down the line. Let's go into this Ozempic boom. Ozempic, Wegovy.
A lot of our listeners actually want to know more about Ozempic and these weight loss drugs, so I figured we should probably cover it for a bit. It's probably going to be a two-part podcast.
This is like, I think we can spend a whole hour on basically this drug class. I know maybe when we recorded earlier, James, like over a month ago now, we kind of talked about these medications, but we basically said how this drug class, when we're going back again 10 years ago, it was really a second line tier, the GLP drug class, in terms of second or third line treatment option for diabetes. But a lot of agents have come out since then that have been great at, number one, treating and lowering blood sugars, helping with weight loss, and also have a really great positive cardiovascular benefit for patients. And the kind of like the big hit drug from this category right now is Ozempic. So I'm sure all of our listeners have heard of this. They personally know someone that's been taking the medication. And I saw this article, and I'm just kind of starting off this one. And I think there's plenty of opportunity to do a deeper dive in terms of how this drug class, how these medications work, or the pros and cons of these medications. I think we can save that for a different episode. But for this one, obviously people are aware that sometimes, when these medications, they have these great benefits, but they also come at a great cost. And, I believe Ozempic roughly around $1,000 a month cash price. And obviously some insurance companies, if they start to see an uptake in these medications being used for people who are not actually diabetic, or trying to use it for other reasons, like for weight loss, they're going to crack down. And something that we've kind of seen transpire over this past year, where a lot of people are not getting these medications covered. And this article is kind of an interesting one to me, because it actually said that this could be a net positive for pharmacy benefit managers, those PBMs we talked about. And just at a really high level, why that's the case is some of these drugs, since it's a competitive space, if you're looking down below, they list about 4 drugs. If you scroll down, James, 3 of them are actually from the same manufacturer. They're just kind of different formulations. Ozempic and Wegovy are both injectable. Robustus is a tablet. And then there's Mounjaro from a different manufacturer. It's the newer agent. It's actually probably the one that has even more efficacy in terms of weight loss, but it hasn't received that approval yet from the FDA. There's a lot of discounts. Look at that. It says average discount from list price to net price, and it's between, on the low end of 50 with Wegovy, but upwards of 80% on Mounjaro. So when you usually see this, the rebates can be in the form of a discount at the pharmacy, but it could also be in the form of a rebate from the manufacturer. And we've always had this conversation where rebates are really like a black box in terms of pricing. Not a lot of people have insight into the rebate contracts between these manufacturers and the PBMs. And there could be a possible percentage of that rebate payment that's, instead of going to your employer or to the health plan, is retained by the PBM. So this is obviously a big revenue stream, because more people taking these prescriptions just means more opportunity for these companies to make money. So I just kind of thought it was an interesting article, an interesting take, that this is obviously a net boom for these insurance companies and these PBMs, with more and more people utilizing these medications. So I just kind of want to throw this out there. I do think that we should come back and do like a whole deep dive on this category and cover it kind of A through Z, but this is just one recent article actually earlier this morning. So thanks for bringing it up. And any
Yeah,
thoughts on this or questions?
it's pretty interesting. I mean, yeah, to your credit, I remember when we were in pharmacy school together, this was just originally intended as a diabetes medication. And one of the side effects was, of course, weight loss. It was a great drug for lowering your blood sugar, lowering A1C. But like you said, it was, 3rd or 4th tier in terms of the treatment algorithm for diabetes. So it's side effects of weight loss. I think that's really what caught on. So it's kind of interesting how this whole industry sort of boomed and was built from that. Kind of reminds me of Viagra and sildenafil. Originally, it was just for pulmonary arterial hypertension, and they started realizing then there's a side effects for erectile dysfunction. It would solve for that. So it's pretty interesting. But one thing I wanted to point out is that there's actually compounding pharmacies. I think they're 503A or 503B pharmacies that will actually compound semaglutide, and it will be compounded with like vitamin B12, and they'll actually sell this for about $250 to $500 for a month supply. So it's still a lot cheaper than Ozempic itself. Ozempic is obviously the brand name, but it would come in a vial. So I thought that was pretty interesting. I've seen a lot of people sort of, instead of getting Ozempic at the pharmacy, they would just go to a compounding pharmacy and they'd have access to it from there.
It's not just the access, with these, because you're able to buy that, or there's also clinics, I think, that charge $75 to $150 a week to get your injection in the clinic. But all of that is stemming from the simplicity of availability. Like, I haven't been able to order the higher doses of Ozempic, 1 milligram, like in 2 weeks, and 2 milligram in 6 weeks. So if you have a patient that's stabilized on this medication for their diabetes, they're not using it for weight loss, because Ozempic is indicated for the diabetes indication. If they're not able to get their medication, it's just a cascade of effects that happens. They're not, their A1C starts going up, their blood sugar starts going up, they're not able to get their meds. They have to go on to different oral therapies. Well, then there's a compliance issue. It just continuously cascades into bigger problems, in my opinion, with the boom. So there are these clinics popping up. You are able to get it from a compounding pharmacy, but I think the manufacturers really need to hone in on being able to supply the demand that they've created. because I get 3 to 4 phone calls a day. Hey, do you guys have 2 milligram dose? Do you guys have Wegovy? Do you guys have this med, that med? But the answer is always no, because we just can't order it. Which is,
I
and a
think
lot of doctors want to prescribe it because it actually does work and it works very well, but they can't because you can't get it.
One thing,
I think
go
ahead.
yeah, I mean, there's always this ethical debate, right? And I know a lot of pharmacists are kind of stuck between, well, do I service who brings in a prescription first, or should I reserve it for people who actually have diabetes versus people who are just using it for the weight loss indication? And I kind of wanted to get your thoughts. I mean, is it right that a healthcare provider has to triage and essentially figure out who's more worthy of receiving these medications? Or do you think it's not really up to our discretion to really sort of pick and choose who gets to treat it or not?
I think diabetes, the indication of diabetes, is more important and supersedes the weight loss indication. That's just my thought, specifically because diabetes can be debilitating and has more downstream consequences than just being overweight and having a hard time losing weight does have its downstream consequences as well. But there are other non-pharmacological options that you can do to mitigate that. Those don't apply. They do apply for diabetes as well, but not as, I guess the right word is, it just doesn't help as much and as quickly. I think treating the issue at hand is more important, simply put. I don't know your thoughts, Boas. Maybe do you think anything differently, or?
I mean, they're both. I mean, you have to realize that it's basically most people who are obese probably have a chronic condition like diabetes or hypertension or
Right.
cholesterol. So I think it's kind of hard to say. It's really difficult. Medications are so effective at treating blood sugar, but they're also very effective at losing weight. We've seen a ton of people put off 20, 30, 40, 50 pounds on these medications. For me, I wouldn't really prioritize one over the other. It's just ultimately, if you have a patient who's established with you, and if you're unfortunately only limited to like 4 of these doses a month, and this is your routine patient, then it might be better to allocate and ensure that patient's continuously staying on that medication instead of giving it to a new start patient. I wouldn't really know what's the right or wrong way, but obviously we know what ends up happening if therapy is interrupted, if people go off their medication for a couple of weeks, things can really have devastating effects. So from at least what I've kind of seen, I'm not sure, you're on the ground, like in terms of in the pharmacy. So you're saying there's still a shortage. It's unfortunate. I know from just kind of like hearing from folks, it looks like at least things have improved a little bit compared to earlier this year. But it's unfortunate. I think like another topic again. This is not to like kind of go on this too much. I didn't want to like deep dive into this category today, but it's also like insurance coverage is an issue too because these medications are very expensive, and now people are cracking down in terms of making sure that people with diabetes are using the medications. Some insurers don't cover treatments for weight loss. So it's interesting to see how this plays out. Like I really think that obesity should be considered on the same level as diabetes, because if we can help people prevent them from gaining weight or help them lose weight, then we can prevent these diseases from developing in the first place. So I think it's obviously not an approach that you should medicate only. I think what I've seen popping up is a lot of basically combination of a coach, like a nutritional support and medication therapy. There's some vendors out there, some entities who are basically providing that type of a service. And I think for me, I see value long term in medications like Wegovy and so on being combined with diet and exercise to really help people lose weight and stay off weight, and then eventually like tobacco cessation, and even substance use disorder, where you basically have that combination of therapy and medication. This medication assisted therapy results in the best outcomes for patients, and I think that's the future we're going in. And I'm kind of like, I think we'll see a lot of things develop in the next few years around this space.
Yeah, 2 of these 4 injectable products, actually, when you get your first prescription and you can sign up through their websites, they actually have a kind of a bridge program type thing where you get copay savings for the manufacturer, and then you also get like an assigned coach or some sort of thing to kind of go with your weight loss journey. So they're integrating that, but we'll see. We'll see. I just hope that the availability gets better. I actually reached out to the manufacturer of Ozempic and Wegovy to kind of ask, and I had somebody come by yesterday, and they told me that it should normalize by January. But we'll see because
Okay.
they said that last time too. And lo and behold, we're in a shortage again. So
I'd love to be the drug rep for one of these drugs.
I hammered. I asked them all the hard questions, and I got maybe one good answer.
That's
So
hilarious.
I'm like, it is what it is. At the end of the day, you can't really do it, you know. They said that there was a manufacturing issue with one of their contractors, but it sounds
So
like a very
just like a funny note on
overhead.
this drug class. Again, like we can maybe end it on this too. Or I think Armin, you might have one more article. Sorry, but it's so when Denmark was reporting their GDP figures, they had to exclude the GLP drug class from the country because Novo is a Danish company. So the country of Denmark, when they're reporting their GDP figures, they had to remove the GLP drug class from the figures so that their GDP growth wouldn't look way too high. Which I
That's
thought was crazy that
hilarious.
a country this company is now worth like $500 billion, I think, if I'm not mistaken. It's insane, and it grew very rapidly. I mean, they were maybe a I don't know 40-50 million dollar cap drug, $1 billion cap drug. Now they're 10 times that, so had a huge impact on the country's GDP, and they had to carve this out from there, which I thought was wild.
It's pretty insane. Is it because I mean they're probably not using it for weight loss in other countries except for America? I imagine that's probably taking up
Um,
the bulk of the revenue.
yeah, it's
Well,
actually
you just gotta.
$328 billion market cap, but yeah, I'm still most of their consumers are in the U.S., especially for Wegovy.
Yeah,
Market share is probably
they're making a killing off these bands for sure.
Let's segue into the last article that I put up.
Sure.
The Ozempic maker testing it on younger patients. Listen, I think it's our responsibility to bring up sensitive topics and maybe triggering topics. And for me, I think this is one of them. I just want to get your guys' take on how these drug companies are testing these drugs and on the age of kids that are now they're trying to get indications for to get these kids, frankly, kids started on these medications. The gist of it is that they're trying to, right now, I think the age is 12 and older. You can use it, it's approved, but they're trying to get that down to the age of 6. So, what's your guys' take on children, frankly, using these medications? You think it's beneficial? You think there's other options that families should consider? What are you guys' thoughts? Just an overview before I give my 2 cents.
Well, I mean, this article
yeah.
says 1% of weight loss prescriptions. Teenagers only make up 1% of weight loss prescriptions for newer GLP-1 drugs. So there isn't really a lot of usage in kids right now. To introduce this to us, kids as young as 6 years old, it's weird.
There's a lot of development still going on in the body. So I think to introduce, an exogenous substance or agent or medication like this to a developing child, I don't know. I personally wouldn't. I don't know what you guys think about it. I think there's plenty of other ways for kids to stay active. I mean, you guys remember when we were 6 years old, we'd be running around outside, biking, playing with our friends, playing sports, you know, playing in the dirt for some people, maybe, I don't know. But we were out and active,
Yeah,
right? Constantly active.
yeah,
We didn't have phones, we didn't have iPads, we didn't have a computer. We had nature and we had to go outside and figure out what to do for fun, right? I think that's a big contributing factor to why there's higher instances of obesity in children these days. Most kids are glued to their iPads or their computer screens or playing games or whatever it is. It's just the physical activity component isn't as prevalent as it used to be. And I think that's the largest contributing factor. I don't know what your guys' take is, though. I'd like to know.
yeah. I mean, honestly, I'm kind of going to just be very neutral on this. I think it's different for some people. It's very easy to get motivated and get out there and be fit. for a 6-year-old. Like I grew up struggling with weight even at that age, and I tried to play sports like karate, basketball, soccer, and I really never really lost weight. I mean, I would participate, I would be involved, I'd be very active on my bike, scooter, this, that. I was never really a video game person, but I just like to eat. And, I was a chubbier kid. So if there's people out there, sometimes it's a genetic predispositions, we all have food insecurities. There's a lot of just things that you really don't, that go beyond sometimes diet and exercise. And I think if it's something that can be safely used in patients, sure. Should it be first line? Perhaps not. I think there should be other things that families, and obviously there's so much burden and stress already on educators and teachers, but there should be other opportunities for kids to try first. But if it's not working out, maybe a short-term course can be beneficial to at least help them get into shape. And then once they have an understanding of or feel more body positive, if that's one of those things that people are making fun of you for being overweight, and once you kind of lose some weight, you start to feel better about yourself. You can sustain that through picking up a new sport that you previously were afraid of trying. It could have some benefit, but I wish, again, I'm just going to go to that thing that we shouldn't really treat obesity any different from asthma, because if we have an inhaler that can work safely for a 6-year-old, and if this therapy can also work safely, then I think it should be something that's on the table, but not necessarily maybe just in the case of obesity. There should be other options exhausted maybe before you resort to this, but I think it should be available if it works, if it's safe and it works in patients.
That was my take. I mean, it should be an option, but it shouldn't be the first option when there's so many other things that can be done prior. I see the precedent kind of being set with adults taking or using Manjaro or Wegovy to lose weight as like a first line. And if that precedent is that set for the next generation and kids are doing the same thing, to me, I think it's not the right approach. Obviously, if there's a serious health condition where it's just, the weight can't be lost, or there are health conditions where, it just is what it is. For them, perfect. Of course, this is the only option that's going to work, and it'll work great. And, kids will have more confidence. They'll have more, interactions with other people. They won't feel so insecure. All those things are very important, especially when you're developing at a very young age, and
yeah, I think right now, I mean, the treatment algorithm for a lot of weight loss drugs before GLP-1s, I mean, they were all stimulants. Cusemia was actually a drug, I remember. I think it's like phentermine. Something else in it.
Safer options. Yeah.
There's safer options.
I mean, definitely, again, it's very unknown right now with these drug classes. I think that's why it deserves such a deep dive, because we don't really know the outcomes of discontinuing the medication. Do you gain the weight back? Do you gain more weight back? Do you keep the weight off? There's a lot of question marks that will only come out over the next 5, 10, 15, 20 years once people are consistently taking these medications. So there's really it's very new. It's like these all started kind of I think Ozempic was released in 2018. So it seems like a long time ago, but in the world of drugs and evidence, it's really not. And we're going to need to study these a lot further to better understand them in both adults and pediatric, younger children. So
sure.
I don't know, maybe kind of end it there for the GLP topic. Yeah. Do you guys have anything else to discuss? Any other fun articles or anything you guys have come up across?
No, we're going to do for our audience, we'll do a full episode on this class of medications because it does deserve, and frankly needs a lot of exposure. So we'll go ahead and do that in the coming weeks. I don't have anything else new to bring.
I don't have anything else on my end, but until next week, I guess.
All right. We'll end it at that.
All right, guys.
Thank you everyone for joining.
We'll see you.
We'll see you guys next week.
Take care.